Hi everyone, we've just got to 12:30, so we'll make a start and hopefully we'll get more people joining us as well, but we've got a fantastic number registered today. So this is the first event that we've held, which is a webinar directly related to a project. So this was the BSE N-StEP project. It's a really exciting collaboration, a partnership really between the BSE, the University of Oxford and the Clinical Research Facility at Oxford. And it's one of the first projects that's been aligned with the Research and Audit Committee of the BSE, and I'm a proud member of that. So my name's Maria Paton and I help co-lead the committee. And this is a fantastic collaboration across more than 30 NHS trusts to really give you a review of stress echo practice in the UK. And the reason that we're here and doing this today is that we've got a really fantastic opportunity to allow people to put in expressions of interest before the 5th of August to be able to use some of the data that's available through the project for research projects or research ideas that come across you that might be able to help you clinically. So what we wanted to do today was provide you with a really good overview of the project, what kind of data that we can get as a snapshot from some of the data that we've collected, and how that might be able to help you clinically. And we've brought to you today because we think that that's a really exciting opportunity for you to be able to get involved in some of the research that's going on and really help drive things for a national level, really, to get involved in some of the BSE projects. So with that in mind, please put any questions that you've got in the question box. We've got a panel discussion booked for the end of the session, so we'll answer all of the questions in there, and any that we don't get through, then we'll seek to answer afterwards. And just to remind everyone that the Twitter handle for today is BSE N-StEP, so please feel free to tweet about the session as well. So our first session, our first speaker really needs no introduction. Professor Paul Leeson is a world-leading cardiologist and a professor of cardiovascular medicine at Oxford, and he's going to share with you today an overview of the project, the BSE N-StEP project.
Great, thanks very much, Maria, and thank you for the introduction and giving me the opportunity just to talk today a little bit about the BSE N-StEP. So I'm going to share my slides with you, and we'll go from there. Hopefully you can see that okay. So I'm going to open really today with a talk about a little bit about BSE N-StEP to try and address that question about what is it exactly, why does it exist, and what we're going to be able to hopefully do through BSE N-StEP as it takes shape, and also really set the scene for.
Paul, sorry to interrupt. We can't see your slides at the moment.
You can't see the slides. Okay, that
no.
All right. Does that?
That's bringing them up. Yeah.
Let me just do. Can you see? Is that the presentation?
Yeah, that's brought it up. Thank you very much.
Oh, so apologies for that. Apologies for that. Great. So great. Yeah. So BSE N-StEP. What is it? How has it come about? And what are our hopes for it? And one of the key drivers for this seminar is not just about talking about BSE N-StEP more broadly, but specifically creating an opportunity to open up the data set we have to ideas coming in from BSE members, and I'm going to explain why that is important to the rationale for why we have the BSE N-StEP. So if we get back to what it's all about, it really is about stress echo, and hopefully everybody online who's joined is aware of that. This is the stress echo, the most commonly used functional test for looking for coronary disease, certainly in the UK, and widely used across Europe and the rest of the world. It forms part of nearly all guidelines for management of coronary disease, for assessment of chest pain at different stages during life. As I'm assuming that most people who've joined know what stress echo is, the fact that it's looking at the heart with ultrasound and looking at how it responds to a stress stimulus, and really looking for regional wall motion abnormalities. It has been available for at least 20 years within a lot of hospitals, but the nature of stress echo is such that it does rely on expertise and expert operators who can both look at the images and pick up regional wall motion abnormalities that are emerging by eye. This is a summary of a whole range of studies. This is actually about 60 or 70 studies which are presented in a systematic review and meta-analysis a few years ago, looking specifically at sensitivity and specificity in the type of studies that have been reported. Now, it's fair to say these studies would go back over a long period of time when technologies were not as advanced, when there was a different range of expertise. Also, these studies are very different study samples as well to look at. But I think one of the things that come through is that actually sensitivity, specificity for this test does vary quite significantly across these studies. Now, you can take average levels and say, well, on average, this is what we get for stress echo, but it also highlights that these studies have been done in different centres with different sizes, but actually for any one centre, it's likely that sensitivity and specificity is going to be varying by stress echo performance and with the operators. And this variability is one of those concerns about stress echo when you're delivering this out at national scale across a health system such as the NHS. If one hospital is performing and has quite a poor sensitivity and specificity, that's going to be really relevant to patients in that hospital, even if we know the average levels of performance stress echo are very good across the patch. But it's very important that we maintain a quality of delivery of stress echo in every hospital we can do so within the UK. With that kind of in mind, the idea that could we improve, first of all, with that in mind, what we wanted to do was really examine the performance and accuracy of stress echocardiography. We decided to set up a project called Everest about 5-6 years ago now, perhaps a little bit longer, with the idea that what we want to do is not look back at stress echoes being performed, but prospectively recruit patients who are coming forward for studies to try and capture real world data, not just academic studies of stress echo, but actually what was happening in terms of what the kind of patients were that are coming forward with stress echo, how the stress echo was actually being performed in different hospitals, what happened to the patient over the next year or so of their stress echo, and also start to build data sets which will allow us to look at the real cost of stress echo as it was being performed and the downstream costs. We also had two other requirements for this. One is that we wanted to catch the images because we thought that would be of value and interest for understanding what might be varying between centres. And we wanted to collect blood samples so we could do some analysis to understand whether there are other markers which might be of value. If you're wondering what Everest stands for, then it stands for echocardiography, value and accuracy at rest and stress. And this is the timeline for the study. So we started back in 2015 and we started off just in Oxford and we started collecting some images. A couple of years later, once we'd set up systems for being able to do this, we added on 6 new sites in 2017. And as we got more ambitious, we brought on board 9 new sites. And then in the final phase, late 2018, we brought on 11 new sites. So we had about 20-25 hospitals at this point, and we continued recruiting with that number through to early 2020. The first phase of hospitals, between 2015 and 2018, were really based around the Thames Valley, local hospitals who we've been working with for many years, and also through to Swindon and Bath, who were part of the early design of the studies. They were very much involved in thinking through how you do such a study. The second phase of studies was really then opened up to anybody who wanted to take part. Now we brought a group of motivated and keen studies on hospitals on board to join us for that phase. And then the final phase was an expansion out to quite a lot of centres mainly within England at this stage. During the first phase of recruitment, when we were just in Oxford, we recruited about 370 patients. By expanding out to the rest of the Thames Valley, that started to accelerate. We managed to get up to 800 patients. And then it really took off as we took through the other phases, so that actually by the end of 2019, we'd recruited just over 5,000. And by the point of reaching our planned recruitment date of March 2020, we had over 8,000 patients recruited across the UK. This was, I have to be honest, this is 10 times what we were started off with in those first phase 1 and 2, and substantially more patients than we had thought we'd be able to recruit when we started out. And it really represents the power of the UK in the ability to recruit patients, and also the NIHR Clinical Research Network to link together sites in a way that delivers research at scale with relative simplicity in terms of getting sites working together. And so this really does represent an ability of the UK to recruit patients at scale for these type of studies. The kind of hospitals were involved, we were very keen to make sure that it was representative of the UK. And indeed, if you look at things like multiple deprivation ranking of hospitals, size of hospitals, number of cardiology attendances, number of stress echoes performed, we were able to very effectively involve within Everest and the Everest sites a true representation of UK practice and UK healthcare experience. And when we brought this data together and published it on behalf of all those people, all those centres who take part in the Everest, these are the kind of data we came back with. So remember, that slide I showed you at the beginning really showed variability, sensitivity, specificity across lots of hospitals, across lots of studies, reporting single centre experience largely. And this is the first time we've been able to bring together data representing the whole of the UK, real world practice. How is stress echo actually being performed in these centres? And this is the data cut on the first 5,000 patients, in which we had follow-up 3 to 6 months. And it showed things like, actually, in the UK, we're using 70% of studies are being done with contrast. And this is something that's quite different from Europe and the US, where a lot less contrast is used. It kind of reflects what we thought was going on in the UK, but actually we can now prove that is actually what's happening. 70% of studies with stress echo are done with contrast. 70% are done with dobutamine, and about a quarter are exercise, and a very small number are done just with a pacemaker. When we looked at predictive accuracy, I think this was really striking. So this is taking all centres across the UK. What we can see is actually it's being delivered with a very good level of accuracy. Now, there is a caveat to the way we're presenting this accuracy because it is real world data, and therefore we have to base this off what we see within angiograms. We know there are a cohort of patients who don't go forward for angiography, and we assume that they are well, and unless they come and have an acute event, we will class them as having have had a good outcome from the stress echo. So what we're looking at is really the sensitivity specificity is based off those people who go forward for angiograms, whether they have had positive disease on the angiogram, which would suggest that they require that angiogram, versus those who didn't have disease on the angiogram, therefore it was felt to be an unnecessary angiogram. And we're comparing that also with those who potentially had a normal stress, who were told they had a normal stress echo, but came back with an acute event. So there's a slight case selection bias around those who are attending healthcare. But actually, that's not unusual for quite a lot of studies which are performed within imaging. And certainly, those levels of accuracy are very reassuring in terms of the amount of false positives and false negatives that we're getting within the stress echo performance in the UK, suggesting that uniformly across the UK, stress echo is being performed to a high standard. Because of the scale of the data, it also allowed us to look at some subgroups to understand whether any factors which might be influencing the accuracy of the stress echo. And what we found was actually pre-existing coronary disease, younger patients. It was actually made it slightly more difficult to pick up the positives and negatives within the stress echo, and that's something we can learn from about how we might need to take more care in those type of patients. And then you may have noticed our timing when we planned to end recruitment in March 2020, and this happened to just coincide with when we had a sudden emergence of COVID within the UK, and a pandemic hit, which meant lots of services closed down, and we suddenly changed our focus. We were actually incredibly fortunate that actually our 8,000th patient was recruited about 2 or 3 weeks before the pandemic, the lockdown started. And so we had actually completed our planned recruitment at that stage. And we could, for the next few months, go into a phase of data processing, data analysis, data cleaning. And we had the luxury of being able to do that with people working from at home very hard to bring all these data sets together and start writing up some of these findings. But also it was a time of reflection, I guess, working from home, thinking about what had been done and what we could take forward from this, the future. What we certainly didn't want to do is leave this at this point because of the relationships we built up with different centres, different hospitals, and understanding what we could take forward from this into the future. And that's when we really had some conversations with Maria and particularly Dan Augustine, who I've known for many years, and the British Society of Echo. Start to map out whether actually we could start to do something more structured that was supporting British Society of Echo and the UK into the future, and start to extract more information from these data sets having been collected. Having demonstrated the possibility of doing this type of work, we really wanted to now embed this into how we thought about stress echo and indeed echo practice within the UK. And so over these months, we put together some plans. We had discussions with the BSE executive, we had discussions with the BSE education and research committees, And we brought together a new structure for how we would continue to deliver essentially the Everest project, but renamed the British Society of Echo National Stress Echo Practice Review, and signed some agreements about how we would operate this between the British Society of Echo and the University of Oxford, with the University of Oxford continuing to develop the project and act as custodians of the data, but sharing that data for BSE and BSE members' use for research purposes. And then in September 2020, we relaunched this process with the plan to start recruitment restart with addition of new sites across the UK and the start of a new phase of the study. It was actually just literally the 1st September 2020 that we relaunched the study under the auspices of the British Society of Echo N-StEP committee. And we really did want to highlight this as, you know, actually this really is quite important. This is the first ever review of the performance of an advanced echocardiography imaging modality within the NHS in a structured and organised way by one of the professional societies of an imaging modality. To oversee the BSE N-StEP, we have a committee who meets relatively regularly to look at what's going on within the study, monitor how it's progressing, and thinking up how we make use of this for the value of the UK NHS. It's chaired by Dan Augustine in Bath, and on the committee there's the names, and some of those names you'll see presenting today, including Maria, Shaun, and James, who'll be giving a recorded presentation, but also Keith and Jamie Driscoll, David Oxborough, and Mark Monaghan are involved in delivering the study, and is very ably managed from the Secretariat side in terms of administrating project managing this, with Casey, who will also be talking today. So what's happened since September 2020? Well, one of the first things we were able to do was address a really quite important question, which had been being under conversation quite a lot at the time, which is what actually happened, what impact was COVID-19 on UK stress echo practice? Because we had data running up to March 2020 and we restarted recruitment in September 2020, we were able to very effectively start to understand what impact COVID-19 was having on UK practice. There had been conversations about, stress echo, COVID, no one's going to do stress echo now, it's going to be the death of stress echo, we'll go on to other things. And that really didn't feel like the reality of what was going on the ground. So by having real world data being collected in real time with questionnaires collected at each of these centres, we were able to track exactly what impacting COVID-19 practice. And what we find here is in the purple on the left, we have the number of patients being seen on each list, the number of lists per week. On the purple on the left, we have what practice was pre-COVID based on our existing Everest data. We have the blue, which is what was happening in the summer of 2020. And then in the red, we have what was happening by Christmas of 2020, early 2021. And we can see actually the number of patients per list did drop off slightly during the first wave. So there was obviously a slight reduction in the number of patients being seen. But by Christmas, actually, the number had increased. And if you look at the number of lists per week, again, that dropped off during those early phases of COVID, but had returned to pre-pandemic levels even during the subsequent waves in early 2021. And so this really fixed in our mind that actually, yes, there had been adaptations required to stress echo practice, and we were able to map out exactly what those adaptations were. It had declined, but actually there had been a relative catch-up of activity so that it was returning back to normal levels by the time. This was incredibly useful in terms of mapping out exactly what was happening and what impact this was using the data network we had. These are the current set of sites. So we talked about wanting to expand the number of sites. One of our objectives was to make sure this was truly a BSE organisation, so it's a UK-wide study. And so we brought on board centres in Scotland as well as England to make sure that we had representation across the country. We also brought on new centres in Leeds and Bristol. And also we did one or two centres, sadly felt they had no longer time to participate, but they were more than compensated by new centres that came on board. And we're now recruiting from 32 hospitals in the UK. This is a snapshot of where we are right now. This is actually probably about a week or two ago, 12th of July. So these are the census recruitment. Just within the BSE N-StEP project, we recruited a further 5,000 patients. So our total recruitment over the two studies is around 13,000. And our target recruitment by early 2023, so over the next 6 months, will be to reach 15,000. And for us, that'll be the moment where we'll reflect again on what we do next with this study once we have that data set available for use. I mentioned earlier on that actually we are following up these patients for 12 months after the stress echo and looking at what happens. This is some of the data we have and looking at when events occur after someone has a normal stress echo or an abnormal stress echo. And you can see that actually if you have a normal stress echo, the chance of you having an angiogram or coming back into hospital with something is incredibly low for the next year, which is very reassuring that actually those people we're calling normal truly don't have any problems and don't need any further investigations, even if they're being managed medically for cardiovascular risk. Whereas also you can see that actually if you are told your stress echo is abnormal, you've got a reasonable chance that something might happen. It may be that you have an elective angiogram, or it may be that other events occur over the next year, so some action is required for that group of patients. However, the other key thing we brought on board with the BSE N-StEP process is to extend that follow-up. So we have gone back and gone through a fairly laborious process of re-consent of patients who did take part to be reconsented into a 10-year follow-up through NHS Digital. And all new patients who are being recruited since the start of BSE N-StEP also consent to take part in the NHS Digital process. So all new patients at September 20 are consented, and probably about half to 2/3 of those previously have agreed to take part in this long-term consent. And this will really allow us to start to expand our horizons now in terms of understanding how stress echo performed at a particular point of time, how that relates to future health outcomes over a longer period of time with a simplified follow-up process. Which really brings me to my final slide. I'm going to spend a little bit of time talking about this, which is what has this effort generated over the last sort of 7 years, and how can we make use of it? So one of those things that I've talked about is how it's allowed us to look at COVID-19 and how that's the impact of that on stress echo practice. It's allowed us to look at current accuracy of stress echo in the UK and describe the kind of types of procedures that are being done. There is work going on at the moment doing that real-time health economic analysis, looking at outcomes over the 12 months after the stress echo, and that is developed quite nicely. There's also some other work you'll hear about today related to workforce use. But essentially what we have is a data set of 13,000 patients at the moment, which will have reached 15,000 by early 2023. This is a group of patients who essentially have been presented with cardiac symptoms. They're often typically chest pain, but breathlessness. For this cohort of patients, 15,000 patients who are presenting with these problems, we have information about their indications, their medical history, the time of study, including medications, what other medical problems they have, what other comorbidities they have. We have very detailed information about stress echoes before.
Good afternoon.
Stressor, the operator's complications image analysis. And we also have follow-up data to 12 months, and also including what investigations they have, angiogram reports, and we have access to the raw information about these studies, and including the outcomes and their hospital admissions. And we now have for about nearly 50 to 70% an NHS digital follow-up, and are planning our first data cut extraction for this digital follow-up in the later half of 2022, where we'll essentially capture information on everybody who's taken part so far. So we'll have 7 or 8 year outcome data on some of those early patients, and we'll have 1 or 2 year outcome data on some more of the recent patients. And the question that we hopefully set the scene for is, with this knowledge of the data set, 15,000 patients, of patients across typical patients presenting to UK hospitals with coronary disease, we have this beautiful detailed data set, and what further questions might be of interest to study in this group. So I'm going to hand back to Maria now and stop sharing and let you hear more about the study.
Thanks, Paul. That was a very thorough overview and hopefully really has stimulated people into what some of those research proposals might be in the future. And clearly this work has already been really impactful, but I know, from lots of our committee meetings that we want to make sure that there is the most, impactful that we can possibly use to get this data out there into the world and affecting guidance and making sure that we're making changes to clinical practice. So it's really fantastic that we've got such a detailed overview, because hopefully that'll give people all of the information they need. But please just remember everyone to put questions into the chat, because we'll be able to discuss some of these intricacies a little bit further in the panel discussion. Thanks, Paul. So we've next got a recorded presentation from Dr. James Willis. So James is a senior cardiac scientist in Bath, and he's also on the higher specialist scientific training pathway. So as part of his HSST project, he's looking at some of the practicalities around leading a stress echo service, but using some of this data nationally.
Good afternoon. My name is James Willis. I'm a clinical scientist for the Royal United.
So we'll start that now. Are we able to start that presentation again, please?
Good afternoon. My name is James Willis. I'm a clinical scientist for the Royal United Hospital in Bath. My thanks to the BSE for asking me to talk about some of the early data coming out of the BSE N-StEP project. I'm here today to talk specifically about insights into real-world workforce data for UK provision of stress echo. So one of the key things I want to do in today's talk is really give you some information from the key early data that's coming out of N-StEP. With this in mind, it's important to remember that N-StEP is still live. So we're still actively recruiting patients from a number of different centres across the country, and likely by the time this presentation goes out, there'll be another couple of hundred patients that have already been recruited into the database. But I really want to be able to give you some key insights, some takeaway facts that you can consider with regards to workforce. That's what this presentation is going to focus on. So prior to N-StEP, what did we really know about stress echo services in the UK? And the best information source that we had prior to this was the 2014 commissioned Stress Echo in Clinical Practice survey by the BSE. And what this involved was all the trusts around the country being sent an electronic questionnaire with regards to stress echo services, where they focused on 5 key areas, namely service demographics, indications, methods, reporting, and any adverse events. And these were self-reported by each of the centres with regards to sort of median values and numbers undertaken per year. So it gave a good indication as to where the high volume centres were, those centres who were maybe doing less stress echo. But what it's not able to do is give individual information with regards to the test data as it comes out. And this is where the strength of N-StEP lies, is we've got data being collected from the source in terms of the outcome of the specific tests, but also then the follow-up data, which is going to come at 12 months after the patients have been recruited into the programme. So why are we interested in the workforce? Why is this something that's a bit of a hot topic at the moment? Well, if we look at a number of key documents that exist, we know that the NHS long-term plan is well into its term now with regards to expanding what we are able to do as a group, namely sort of physiology services that can be provided, and offering different models of care outside of sort of the traditional settings. This has been highlighted further in the Diagnostics Recovery and Renewal paper that's come out and talked about how we recover backlog in terms of diagnostics and what innovative ways we have to be able to do that, where we could do that, and what workforce we would need to be able to deliver that. And again, the slightly older paper, the strategic review of cardiac physiology services in England, which has gone on the way to sort of help lead and guide some of the modernising scientific careers suggestions that have come out. So we know that the idea of physiology-led services, for example, is nothing new. The data's been around for a long time, and it's got good data to show that actually expanding services away from traditional medical-led services into utilising physiology-led services is a sensible and safe thing to do when implemented properly. And we can see examples here in the paper from Reinette Hampson regarding the use of sonographer-led cardiologist-interpreted stress echo services back in 2019. And we already know that this allows a degree of autonomy where the team will be able to undertake the test as they see fit on the day, but with supervision from cardiologists over the reports once they've been delivered. And these slight variations in clinical modelling are really key and are starting to come through in the data that we see within N-StEP. So we know that nationally workforce is a real hot topic at the moment. We know that there's a push to ensure that we're doing things as efficiently as we possibly can, and we consider all types of ways of working to be more efficient in how we deliver our services. What is known about stress echo workforce at the moment? Actually, very little is known about the workforce itself. Outside of the stress echo and clinical practice survey that was undertaken, there's not a huge volume of information about how individual centres are structuring their services, who's in charge of reporting, whether there's any requirement for further education or accreditation, which we all know is beneficial in these circumstances. And this is where N-StEP really becomes quite key, because it's an opportunity to gather data en masse. And as I've identified already, the volume of data that's going into this is massive. And the key feature here is that it's actually able to focus on all types of stress echocardiography. So we're not just dealing with ischemic heart disease here. We want to look about valvular assessment. We want to look at perfusion, etc. All of this is really key in understanding what services are being delivered, what the workforce is and how that workforce is working. And importantly, what N-StEP is able to do is now look at the outcomes of those particular tests. So by following the patients up using NHS Digital, we can acquire the information required to say, well, what's the outcome been for these patients a year after actually having this stress test? So what specifically is it that N-StEP's actually there to capture? Well, there's a whole raft of data that we can look at, and each of this information gets put in for each individual patient that's recruited into N-StEP, and that's what gives us this huge volume of data and therefore makes the database so powerful in itself. So obviously we're going to be looking at patient demographics. We want to look at height and weight, prior cardiac history, risk factors, valve disease. We want to understand what the typical sort of presentation is that patients present with when they come to have a stress echo test done. We're going to look at the stress echo data itself. So what was the indication? Why was the stress done? What was the type of stress modality that was utilized? Was it exercise? Was it dobutamine, for example? And on the day, what was the outcome of the test? So actually, was it positive? Was it negative? Was it inconclusive? Were there any complications? Is there any kind of contrast enhancement that's used? And where do these particularly fall within the spectrum of testing that we do? And then particularly, I'm interested in the workforce data. So with this, there's a number of key questions that have been put within the database to give us an indication of who was present in the room, and then overall, what was the roles of those people present within the stress test itself. So we're looking at the primary operator. So who was the person taking the pictures? Who's supervising the test? Who's actually doing the reporting of the stress echo themselves? Was anyone undergoing training? And were there any additional staff present during the test? So just very briefly, we look at some of the overall demographic data as it comes out from N-StEP at the moment. And there's no sort of massive surprises in the information that we see here, with the prevalence for males, average age of 64 years and smoking history. So again, really important to be able to break down those different groups, looking at the different stress modalities, for example, looking at the use of dobutamine. Is there any sort of demographic data that applies to particular groups that we see cause a higher use of contrast imaging, for example? These are the sort of combinations of data that it's possible to pull out of the database now. So if we just take it back a moment to think about the working practices as well. If we went back a few years to look at stress echo services, then maybe we'd be looking at sort of a traditional model of working, which is still employed by a number of trusts up and down the country at the moment. And that's based very much on having a cardiologist and a physiologist, maybe additional staff available as well. Within this stress echo team, they will perform the test. The consultant will then report the results and be responsible for all the additional elements that come with it. So consent and drug administration, managing complications, reviewing images, interpreting results, writing the report, and any recommendations that may come out of this particular test. And this is clearly a common, prevalent model looking at the early data coming out of N-StEP. So the reason why this has been designed is there are key questions that are being asked, and we want to know exactly who is the primary operator. Is there any training? But then who was the workforce present within the room? And this gives us an idea on these two elements of who is it that's conducting the test versus who is it that's actually going on to be reporting the test. And that's really key. That really brings us to our first insight, that actually stress echo staffing models are quite complex. And there is a lot of variation across trusts. And we can see that there's a number of models that have come out of this. So to sort of give you an idea when we talk about how we perceive these and what the roles each person has to play within this. Primary operator. So who was the person taking the pictures? Who was the person next to the patient acquiring the images during the stress test? Who was the supervisor? So who took clinical responsibility for that test, managed it, adjusted practice based on what happened with the patient, decided on drugs that were to be given, when the endpoint was reached, etc. Were there any supporting staff available? So was there anyone else there to help, and what role do they play? Are they there to provide drugs, for example, if there's issues there with regarding clinical professional groups and who can and can't give medication? And then who was the test reported by? So this again is really important because it's quite evident that not all tests are reported by the people who were in the room at the time. So we may have two distinct groups there, and we end up with slightly what's known as a reader model there. So when we look at the people who were present in the room at the time, there are a number of different models available, and there's quite a diverse range across the whole of the N-StEP group, but I've picked out a number of different groups here just to give you an idea of what we're looking at. It's not an exhaustive list, but this is just designed to build a bit of a picture as to what we can see with regards staffing in these particular rooms. And these vary from a physiologist and a registrar to a consultant and a physiologist. We know that there's physiologists and physiologist models, and obviously I'm referring to physiologist here in terms of physiologist or clinical scientist, but we know that there are groups where the physiologists are working together to deliver the service. There's a consultant and registrar model that we can see, and physiologists and nurses and physiologists, nurses and HCAs as well. So these are all available across a number of different sites, and they're obviously convenient for the team that are there working, but it shows that already the workforce within Stress Echo is a lot more diverse than first perhaps thought. This brings us on to the second insight, really, that actually there can be varying levels of autonomy within Stress Echo, and this is evident in how the tests actually seem to be performed and how the information is reported. So with this in mind, so if we look at an example now featuring physiology-based modelling of practice, we can see that there is an opportunity for increasing levels of clinical autonomy that are coming through, and each of these models are prevalent within the N-StEP database in varying degrees, and that's really interesting to see that the spectrum is already there. What's going to be key is the outcome data from these particular models and how people see this expanding over time. So we've already alluded to the consultant-led model where the consultant is performing the test and interpreting the results. And we know that the follow-on from this is maybe a phys-led service where we have physiology team delivering the stress echo, performing it, but the reporting is left to a cardiologist who's reporting in a different location, maybe en masse. And what this provides is consistency in the report. So you have an individual who's reviewing all of the stress, so you're able to obtain that degree of consistency across the board. And there may be benefits here in economies of scale, being able to run a number of different rooms at the same time, and then produce a number of reports en masse that will get reported. And what we also have is a similar sort of model, but where the physiology team is actually then looking to provide reports and interpretation of the test as it's performed live with clinical oversight. And actually what we provide here at Bath is an example. We sit within this third group where we have a physiology team who are delivering the stress echoes, reporting the stress echoes, but then we have clinical oversight from one of our imaging cardiologists to provide opinion, act as a sounding board, MDT, just to keep that clinical oversight, really. And at the other end of the spectrum, we can see we have the completely independent services where we see reports being performed, interpreted, reported, and actions being delivered without any sort of cardiologist involvement. And it's keen that there is no one right model of delivery. There are less in terms of those on the right-hand side at present, with the consultant-led model still being predominantly the most popular model that's out there at the moment. But it's interesting to know that as we pick up on things like stress echo accreditation and that becomes more and more popular, actually the need to be able to report and interpret the reports, which is really, really key in understanding sort of how this can progress, comes through. And we can see that here with regards to accreditation. It's one of the key criteria to be able to achieve it. Accredited members are expected to be able to perform and report echocardiographic studies unsupervised. So we need to consider that actually if people are going to be working towards accreditation, then having this degree of clinical autonomy is really key to allow that to expand. but each centre has to deliver the service in the way that they feel is safe and efficient. And it's not necessarily the case that everyone is going to be able to suddenly jump to delivering a completely independent physiology-led service at this particular stage. So if we move on slightly from the physiology model that I showed you a couple of slides ago, and we actually start to look at the data as it's drawn out of N-StEP, so we can really start to see, well, actually, what are the workforce models that exist using the data that's been plugged in? There are 6 key criteria that seem to be coming out, or 6 key groups that are coming out. And that is, again, predominantly the consultant-led model, as we've sort of alluded to, but also a number of registrar services that are also coming through. And they're a popular group that we'll talk about later on with regards to training. And we see these combinations here where we've got physiologist-led, physiologist reporting, consultant reader, and a true physiology-led service. And these are really important because what we're going to do now is actually start to look at some of the raw data as it comes out of N-StEP and see how this applies to these particular groups as it's been reported. So if we look at the type of stress that's being undertaken, as you can see, big predominance there of dobutamine stress echo with an overwhelming remainder for exercise stress echo, a very, very small allocation of both myocardial contrast and pacemaker stress echo. No huge surprises in terms of the types of stress that's being undertaken. And if we then take this information and apply it to those groups that I've just shown you, we can see that actually there isn't a huge degree of variation in terms of the number of dobutamine that's ongoing. You can see there with the registrar-led and reported service that we're up to 84%, and there's an asterisk associated with that. And actually, when we go back and look at the data and look where it's come from, some of that is driven by a high-volume centre with a particular model. So that's slightly skewed in favour of one particular service that's delivering that. But again, it's important information to understand that this particular group is really key as well. We look at the other elements coming through, so we can see that exercise, if you combine both bike and treadmill, still features, and that makes sense based on the pie chart that we've just seen. But actually pacemaker and other types of stress really low down in terms of the numbers coming through across the group, regardless of who is doing the test and how those tests are distributed. So that really brings us on to our third insight. Actually, when we look at the indications for stress echo, indications for stress are very ischemic heart disease focused. And I think this is one of the things that when we looked at the N-StEP data as it was being instigated, we were really keen to be able to sort of capture quite a wide variety of stress tests and understand exactly what's been going on. In particular, look at the information that maybe is coming out from viability assessments or LVOT assessments, etc., or in particular valve assessments. Actually, almost 2 years on now, over 5,000 patients recruited into the study, and what we can see is that the data still suggests that the majority of stress echo that's being undertaken within the N-StEP group, because that's the important thing to remember, this is data within the N-StEP group, is still very ischemic heart disease focused. And actually the number of valve studies is still very, very low by comparison. And this was a real key finding. We weren't expecting to see this at this stage, but this represents the workforce, and this represents, the workload, and this represents what trusts are currently doing and where the demand is. And this follows when you break it down into those particular workforce groups that we've already identified, that actually the majority of workload across all of the different groups is very much focused on ischemic assessment, chest pain on exertion, or shortness of breath on exertion. So there's no one particular group, no one particular specialist combination. When you look at the workforce model collectively that's specializing in valve assessment or transplant assessment, I think if you start to look at data on a trust level, you might see that there are certain trusts that will specialize in these individually. But again, that's on a trust level and doesn't necessarily follow that would be representative of the entire country. So one of the bits of work that will be done later on is actually start to look at the differences between tertiary centres and DGHs and see if there's, again, a slight difference in the way that these services are delivered, or the type of stress that's coming through. So as I've already alluded to, one of the things that seems to be quite key here in distinguishing who is involved in the service and how the service is run is all about who is reporting it. So who's ultimately accepting responsibility. And it seems to be that when we look at this based on that particular question that's asked within the N-StEP paperwork, reporting of stress echo is mainly consultant-led. Now, as we've already alluded to within the BSE accreditation paperwork, this is really key in being able to obtain accreditation. You need to be able to perform and report the echocardiographic studies unsupervised. And one would hope that maybe this would lead to that degree of autonomy, as you would hope. But what we're seeing is actually 80%, 87% of all the stress echoes are reported by a consultant, 7% by registrars, 6% by physiologists, scientists. But I'm going to say there's a slight caveat here, because actually talking to a number of the centres who are involved in stress echo, we know that the opportunity for that third model, the earlier model that I showed you, where we're talking about a scientist, physiologist-led service with both performing and reporting, but with clinical oversight, that's led to a lot more independent reporting, maybe with just the last stage contributing to the sign-off, leading to higher numbers within the consultant group. And again, the registrar model, slightly misleading there, because I think that predominantly this is coming from one particular trust. And again, that represents what that trust is doing in terms of distribution. But as time goes and more centres are recruiting in, more numbers are coming in from across the different centres, these may change ever so slightly as we start to unpick that data and understand exactly where each centre is sitting on that spectrum of clinical autonomy. The other thing to recognise is that actually when we look at the trusts, the number of trusts involved in creating that 6% for physiology scientist-led service reporting, we see that actually the group is quite big. So there's a number of different trusts, I want to say up to 20 trusts, who are involved in having their physiologist team report the stress echoes and sign off on those stress echoes, again, which is really encouraging to see that diversity within the workforce can exist. So what we're coming on to now is insight number 5, training in stress echo practice and number varies across the group. And again, this is no real surprise. It's quite tricky to define clearly what constitutes training, and without having to go into huge amounts of detail. So we can see here, it's, first of all, it's just a binary question. Is anyone being trained during stress echo, yes or no? And if the answer is yes, I ask you to break down which particular workforce group is being trained, who was supervising the training. And this leads us to make some interpretations of this data with regards to where the workforce is being developed and what the workforce of tomorrow is going to look like based on this. So very simply, was training undertaken across the whole of the workforce group? In 19% of those, yes, there was training being undertaken. And when we break this down a little bit more, there's no big surprises there. It forms predominantly into the registrar and physiologist group, with the registrars just taking the lead with a 52% share there. And this presents an opportunity here really to recognise that actually what are the barriers to training within stress echo? Why are more centres not training people? Why are we limited by who can report stress echo and who accepts responsibility? Now, yes, absolutely, there's governance issues around there, and each centre has to be able to create the model that works for their needs and their staffing levels and the opportunities they've got to be able to perform in terms of room space, etc. But maybe this is an area that as a result of N-StEP, we can look to provide some more guidance on. So in conclusion, just to bring this session to a close, here are the key insights that I've delivered throughout this presentation. Stress echo staffing models are complex. That's clear now from the N-StEP data, and there's lots of cross-trust variation in who is present, who is performing, and who is importantly reporting the actual stress echoes themselves. And this goes hand in hand with the fact that there's varying levels of autonomy within the stress echo workforce, and that's clearly evident with some trusts opting for a consultant-led model, whereas others are opting for more physiology-led services with consultant oversight or completely independent practice in how they're working. Despite the huge numbers of patients that have been recruited into the N-StEP database, indications are still very much focused around ischemic heart disease. And actually, this is one of the things we were hoping to see as a result of this, was a lot more data around maybe valve disease. And that just doesn't seem to be coming through. And that represents clearly then the type of work that's being undertaken across the country. Still, stress echo is mainly consultant-led, despite the fact we've got these varying levels of autonomy that we see. The bulk of the work is still being signed off by consultants. And training in stress echo practice varies across the group, with some centres engaging in multiple different training opportunities, and other centres not engaging in sort of any training at all. And again, this is important to try and understand with regards to the workforce of the future. I'd like to thank the BSE for giving me the opportunity to bring some of this early data with regards to N-StEP. and I hope you enjoy the rest of the presentations.
So that was a really insightful snapshot of the data there from James. So hopefully that's already, you can see how valuable the data is going to be and how we can potentially start to understand how we can affect patient outcomes, and also how we can do some analysis on how we can efficiently drive forwards the National Stress Echo Service. Our next speaker is Mr. Shaun Robinson, who's a leading expert in scientist-led services. He's a clinical scientist and works currently at Imperial College London. And he's going to focus a bit more on this whole idea of performing stress echo in the valve assessment. Again, James has just spoken a bit about how we were hoping to derive some of the data around how we can promote these services and how useful and efficiently we can use the stress echo service to actually help our patients in this area. So I'm sure Shaun will go into that in a lot more detail now.
Thank you, Maria. Thanks. I'll just start sharing my screen. So there we go. So thank you very much. It's a pleasure to be speaking on this webinar, the BSE N-StEP webinar. Sorry, it's not allowing me to. Okay, so yeah, I'm going to discuss the assessment of valve disease by stress echo. I'll start by discussing the modalities available to us for the assessment of valve disease, and I'll then go into more pathology-specific protocols. So I'll focus on aortic stenosis, a number of different patient cohorts within the severe AS groups, mitral stenosis, and then primary mitral regurgitation. So what is the role of stress echo in those with valve disease? Well, irrespective of whether the patient has asymptomatic severe valve disease, whether they have some symptomatic non-severe valve disease, or whether they have valve disease with low flow and therefore an uncertain severity of disease, the primary role of stress echo in all patients is to identify those patients in whom intervention is now recommended. And we have a number of modalities available to us to assess the severity of valve disease and the significance. One of those being the semi-supine bike. Now this comes with some pros and cons. The major benefit of being able to perform a semi-supine exercise echo is that we can acquire data throughout the study. So all the way from very low workload all the way through to peak stress, we can acquire the data continuously. And this therefore provides us with a better correlation between patient symptoms, valvular hemodynamics, and heart function. And it's widely used. So it's very, very popular in Europe. It's certainly growing popularity in the UK, and a lot of our valve parameters have been validated in bike stress echo. Some of the cons, however, it is atypical exercise, so asking a patient to recline and to be tilted onto their side and then exercise is certainly unfamiliar, but patients do tend to become accustomed to it quite quickly, so that can be overcome. But certainly exercising the supine position, the heart rate response is more blunted in comparison to upright, so patients need to exercise for longer to achieve those higher heart rates. The treadmill, however, this is walking is clearly familiar to everyone, so it's easily performed. It's maybe a little bit easier for our more elderly patients than being tilted on a bike. And because they're exercising in the upright position, they can achieve the higher heart rate at a lower exercise intensity, so they don't need to exercise for as long as they would do on a bike. However, the major drawback or the major limitation of treadmill exercise is that we can only acquire data at baseline and peak exercise because we can't reliably and accurately scan throughout the test, and therefore we're unable to identify some of those early subclinical alterations in hemodynamics or cardiac function. And then finally, another method available to us is the pharmacological stress. Now, in the context of valve disease, this is primarily for the assessment of aortic stenosis. So when we have low flow due to left ventricular systolic function impairment, and we're unclear at rest whether the patient has true aortic stenosis or whether they have pseudostenosis, then dobutamine can help differentiate between the two. And I'll come on to that in a bit later. So now moving towards more pathology-specific protocols, starting with severe aortic stenosis. So there are a number of indications for performing exercise in patients with severe aortic stenosis, both symptomatic and asymptomatic. And unfortunately, I don't have time to go through each of these individually, but these can be found in the recent ESC valve management guidelines. But the important point to make is that if the patient clearly has severe aortic stenosis and they are clearly symptomatic, this is an absolute contraindication to performing exercise testing, because we don't gather any more information and this can be unsafe. So how do we do it? Well, if we're using the semi-supine bike, if the patient has a physical limitation, or if there's an element of frailty, then we have a low resistance, a low starting resistance with 10 watt increments at 2 minutes. However, if they're more physically capable, then we can start at a higher resistance of 25 watts with 25 watt increments at 2 minutes. And what are we looking for? Well, we perform a full assessment baseline, assessing LV systolic function and LV diastolic function, looking at systolic pulmonary artery pressure, right ventricular function, and of course our aortic Doppler parameters. It's important that we are able to identify possible alternative causes of symptoms, so looking for indications of coronary artery disease, so looking for regional abnormalities. We know that increasing filling pressures with exercise causes symptoms similar to that of severe aortic stenosis, so a good idea of filling pressures with exercise is important. And then we perform these parameters all the way through to peak exercise. If we're exercising using the treadmill, we're limited to acquisition at baseline and immediately post-exercise, but we do perform the same measures. And the important point to remember is if you're exercising patients with aortic stenosis, we should perform blood pressure measurements regularly, so at 1 minute intervals, to identify any drop in blood pressure. So what do we look for? So if our patient is asymptomatic or claims to be asymptomatic and they have severe aortic stenosis on resting echo, our primary objective is to identify whether that patient becomes symptomatic during stress. And approximately 1/3 of patients who claim to be asymptomatic will then go on to develop exercise limiting symptoms. And therefore, this is a class 1 indication for intervention. What we're also looking for is a fall in blood pressure, a sustained fall. So if we have 2 consecutive blood pressure measures that identify a drop in blood pressure, then this is a class 2A indication, so intervention can be considered. But of course, these are not echo-specific measures. But if our patient remains asymptomatic throughout the test and they don't develop symptoms and they don't have a drop in blood pressure, there are other parameters that we can identify that would help us determine a more appropriate surveillance frequency for them. So if we find that the mean pressure gradient increases by greater than 20 millimeters of mercury during exercise, this identifies a patient who's at 4-fold increased risk of a rapid progression to developing symptoms and requiring an AVR. If this is combined with a resting mean gradient of 35 millimeters of mercury, so if our peak stress mean gradient increases to above 55 millimeters of mercury, this patient has a 10-fold increase of developing symptoms rapidly and requiring AVR. Absence of contractile reserve, so if the ejection fraction increases by less than 5%, or if our global longitudinal strain increases by less than 2%, this identifies or suggests subclinical LV dysfunction. And if the patient develops pulmonary hypertension during the exercise with no pulmonary diseases, then again, this suggests that this is hemodynamically significant AS. Now, although these parameters aren't indicators for intervention in themselves, they certainly highlight a group of patients who are at greater risk of developing symptoms more rapidly. And therefore, we may not want to see these patients just at the standard 6-month surveillance for asymptomatic severe AS. We may want to see them more frequently, at maybe 3 or 4 months. An exercise echo has a role in those with moderate aortic stenosis as well. So if our patient presents and the baseline echo or the resting echo suggests that the valve disease is non-severe, it's moderate, yet the patient describes exertional symptoms, and especially if the valve disease is at the upper end of moderate, if we're pushing on moderate to severe, exercise echo can help identify dynamic increases in the pressure gradient. So if the valve is incompliant, if it's a very stiff and rigid valve, the increase in flow, increase in stroke volume associated with exercise may not increase that valve area, but the increase in flow would certainly increase the pressure gradient. And so exercise echo can help unmask hemodynamically significant aortic stenosis when our resting parameters are suggestive of more moderate to severe AS. We know that diastolic dysfunction is prevalent amongst patients with aortic stenosis. This is typically secondary to the AS-induced left ventricular hypertrophy. And when we consider that 15% of our patients undergoing TAVI also have ATTR wild-type amyloidosis, which we know causes significant diastolic dysfunction, the assessment of ventricular filling pressures during exercise is really important for us to be able to differentiate what is the cause of symptoms, whether it's the increased filling pressures and diastolic dysfunction, or whether it is truly the severity of aortic valve narrowing. Coronary artery disease, we know again, is prevalent in patients with severe AS. So 50% of patients with severe AS have some degree of coronary artery disease. And so if patients are presenting with moderate AS at baseline, then coronary artery disease should be considered depending on what their presenting symptoms are. And we know obviously that stress echo is an excellent modality for investigating coronary disease. And what I would add to this list, if department capacity allows, is that establishing the patient's functional baseline while they have moderate aortic stenosis is extremely useful for our onward surveillance of this patient, especially if we're going to perform that surveillance with stress echo. So irrespective of who we are, whether we're an Olympic athlete or whether we're an 85-year-old patient with moderate aortic stenosis, we will develop breathlessness at some point during exercise. That's the whole point of exercising. And for us to be able to understand what that functional capacity, what that baseline capacity is while the patient has moderate aortic stenosis, really does help us interpret their exercise capacity and the point that they develop breathlessness, then that valve disease becomes severe. So if our department capacity allows, establishing functional baseline when the valve disease is non-severe is extremely useful. So those are our exercise modalities for patients with aortic stenosis, but in some patients with poor left ventricular systolic function and some degree of aortic stenosis, it's unclear at rest whether the reduced valve opening is due to either truly severe aortic stenosis and restrictive cusp excursion, or whether the left ventricular function is just so poor that the stroke volume is very low and the aortic valve is just not being pushed open as much as it possibly could do. So what we'd consider pseudo-stenose. In these scenarios, debutamy stress echo has a role. In the low dose phases, debutamy stress echo has an inotropic effect, so that increases contractility. This therefore hopefully translates as an increase in stroke volume. And if we increase stroke volume and find that the aortic valve area does not increase, but our gradients do, this suggests severe aortic stenosis. But if the stroke volume increases and the aortic valve area increases, this suggests that the aortic valve is not opening at rest purely because of poor LV systolic function. Points to remember: in the BSE guideline, it's recommended that if the ejection fraction is between 40 and 50%, but the flow rate, which is our stroke volume divided by ejection time, exceeds 200 mils per second, then DSE isn't indicated because the flow rate is adequate to open that aortic valve as much as it possibly can do, irrespective of what the gradients are telling us. However, if the ejection fraction is less than 40%, low dose DSE can be considered irrespective of what the flow rate is. So what's the protocol? It's a low dose protocol. Early in the low dose phases, debutamy has an inotropic response, so it increases contractility. But as the dose increases, we see a more chronotropic response, so an increase in heart rate, which is what we possibly want to avoid in patients who have severely impaired LV systolic function and possibly severe aortic stenosis. What we're trying to elicit is an increase in LV stroke volume by greater than 20%. This is defined as flow reserve. And a positive result is considered if we have a peak velocity, or if we find that the peak velocity exceeds 4 meters per second of peak stress, and or the mean pressure gradient exceeds 30 millimeters of mercury. Relative indications for stopping the test are if we get a significant rise in blood pressure, but absolute indications for stopping are if the patient develops significant symptoms, the blood pressure falls, or if they develop a significant arrhythmia. And we will see one of 3 responses to low dose debutamy. So if the patient has contractile or flow reserve, and they have truly severe aortic stenosis, the stroke volume will increase by greater than 20%. But because the valve is severely narrowed, the aortic valve area will increase by less than 0.2 centimeters squared, if at all, and will certainly remain less than 1 centimeter squared, consistent with severe AS. But because the stroke volume has increased, but the valve area hasn't, the peak stress mean gradient will be above 30 millimeters of mercury, or the peak velocity will exceed 4 meters per second. Secondly, if the patient has contractile flow reserve, but they have pseudo-aortic stenosis, so the valve at rest is just not opening adequately because the stroke volume is just so low, we'll see contractile reserve with a stroke volume increase of greater than 20%. But with that increase in volume, the increase in flow, the aortic valve area will increase by greater than 0.3 centimeters squared and will certainly be above 1 centimeter squared. And because the valve is now opening better, the mean pressure gradient changes are minimal. And in those who have no contractile or flow reserve, so the stroke volume doesn't increase significantly, then unfortunately we can't perform any further assessment of valve severity based on the low dose DSE. So now moving to mitral stenosis, we perform stress echo in those with mitral stenosis, typically in patients with rheumatic mitral valve disease. In those with mitral annular calcification and extensive leaflet calcification and some degree of mitral stenosis, they typically present with hypertension. They often have significant diastolic dysfunction with raised filling pressures, small left ventricular cavities, low stroke volumes, and symptoms of heart failure with preserved ejection fraction. And so differentiating the cause of symptoms in these patients is extremely difficult, and stress echo is unlikely to offer more information as a group. So severe MS is defined as a mean pressure gradient of greater than 10 millimeters of mercury. However, this is affected by heart rate and stroke volume, and anything that increases left ventricular diastolic pressure, so significant diastolic dysfunction or aortic regurgitation, will reduce that transmitral pressure gradient. And if the left atrial pressure is increased due to mitral regurgitation, this will increase the transmitral pressure gradient. So things we should consider before we start recommending a stress echo. The BSE guideline for mitral valve disease identifies severe MS as a valve area of less than 1 centimeter squared, a mean gradient of greater than 10 millimeters of mercury, and in the absence of pulmonary diseases, a systolic pulmonary artery pressure of greater than 50. For moderate, the guideline suggests that a valve area between 1 and 1.5 centimeters squared is consistent with moderate MS. So in what scenarios should we consider stress echo for mitral stenosis? So in those with severe MS, if they're claiming to be asymptomatic, we would consider exercise to reveal or provoke potential symptoms, and to look at the hemodynamic consequence of exercise as well, an increasing flow. Does the systolic pulmonary artery pressure increase significantly? In those with what we'd consider non-severe valve disease, so a valve area between 1 and 1.5 centimeters squared, so moderate mitral stenosis, although it's not consistent with severe MS, patients with a valve area of less than 1.5 centimeters squared can be considered for a blue mitral valvuloplasty if the anatomy is amenable. And so in these patients, if they're asymptomatic, we would exercise them to assess for symptoms, but also assess for any hemodynamic consequence secondary to the severe MS, so increasing transmitral pressure gradients and increasing systolic pulmonary artery pressure to help identify that this might be considered hemodynamically significant mitral stenosis. And also in patients who are planning pregnancy, exercise echo can be useful to identify subclinical alterations in the valvular hemodynamics that might identify them as being at greater risk during pregnancy. So the protocol, again, if they have a physical limitation, we can have a low resistance exercise protocol, so 10 watts with 10 watt increments. If they're more physically capable, a 25 watt protocol is fine. Again, we perform all of our measures at rest, full assessment of LV systolic function. Assessment of diastolic function is very, very difficult in patients with significant mitral valve disease and may not be possible. Assessment of systolic pulmonary artery pressure and RV function, and of course our transmitral Dopplers. Then again, we would look at this during the low workload, looking for early alterations in our hemodynamics, assessing our transmitral Doppler all the way through, and again, at peak exercise. Again, if we're performing exercise by treadmill, then we're limited to image acquisition at baseline and immediately post-exercise only. So we may not pick up some of those early alterations in hemodynamics. So what are we looking for? In our patients with severe mitral stenosis, we're looking for symptom development. This will be a class 1 indication for intervention. However, if the patient is asymptomatic and their valve is not clearly severe, or the valve stenosis is not clearly severe at rest, if the mean gradient increases to above 15 millimeters of mercury on exercise, this suggests that the mitral stenosis is more severe. If systolic pulmonary artery pressure increases to above 60 millimeters of mercury at peak exercise, again, this is suggestive of severe mitral stenosis in the absence of pulmonary diseases. But we must remember that in the elderly, the PA vasculature can become stiffer, so it can be a reduced compliance. An increasing flow through the PA, increasing volume with exercise, will result in an increase in PA pressure, irrespective of the degree of mitral stenosis. So we must always consider our increases in PA pressure relative to the increase in mean transmitral gradient. However, if we find that the PA pressure increases by greater than 15 millimeters of mercury within the first 2 minutes, this is less likely to be flow related, and this is more likely to be an indication of pathology. And this correlates with a higher rate of symptom development in patients who have a valve area between 1 and 1.5 centimeters squared. So again, although these aren't indicators for intervention in themselves, they do identify patients who are at greater risk of rapid progression to symptoms, and we would certainly want to see them more frequently than the standard annual surveillance for people with asymptomatic severe mitral stenosis. Moving finally to patients with primary mitral regurgitation, if the MR is severe at rest, then we're clearly looking for symptoms, and this again would be a class 1 indication for performing intervention. If the MR is severe at rest and severe throughout exercise, we don't need to perform a further assessment of MR severity during the exercise. However, if they remain asymptomatic throughout the stress and they don't develop symptoms, then there are a number of parameters that we can consider that help identify their prognosis and certainly help us develop a more frequent surveillance program for them. So if the patient develops pulmonary hypertension, so greater than 60 millimeters of mercury at peak exercise, absence of contractile reserve predicts a decrease in left ventricular ejection fraction in those who are medically managed and don't undergo surgery, but also predicts residual symptoms for those who do have mitral surgery, as well as limited RV contractile reserve. So if the peak exercise TAPSE is less than 19 millimeters of mercury, all of these parameters are associated with a poorer prognosis, would prompt us to see the patient more frequently than the standard 6 months, maybe 3 to 4 months. And there's also a role for exercise echo in patients with non-severe valve disease if they are describing exertional symptoms. So at rest, the MR severity may not be severe, it may be moderate, but we must remember that MR can be dynamic in nature and become more severe with exercise, because we know MR is load dependent. So increases in LV systolic pressure will increase or can increase MR severity. So if we're finding that our patient describes exertional symptoms that are inconsistent with the degree of MR at rest, then we can consider exercise echo to look for a dynamic component. Again, we can use the low watt protocol for those who have a physical limitation, or the 25 watt protocol for those who are a bit fitter. But our order of image acquisition should be color flow Doppler, looking for measures of PZ and vena contracta that we then perform offline. Our MR continuous wave Doppler to be able to calculate regurgitant orifice area and hopefully volume. Continuous wave for our TR velocity and estimating systolic pulmonary artery pressure. And because our patients are describing exertional symptoms, we would want to look for abnormalities of systolic function and, if possible, abnormalities of diastolic function and increasing filling pressures that are separate to the MR. So in conclusion, exercise testing is crucial for identifying those who should undergo intervention and is widely recommended within the valve management guidelines. I would add that exercise echo enables a far greater, more comprehensive assessment of the hemodynamic consequences of valve disease and provides us with more information that would help us plan our surveillance of these patients. However, as we've heard from both Paul and James, that we've had over 5,000 patients or studies submitted to the BSE N-StEP process so far, but of those, only 52 are for the assessment of valve disease. So for those who are recruiting, it's not too late to submit valve stress echo data, and I'm hoping that I've convinced you that stress echo certainly has a role in patients with both moderate and severe valve disease. Thank you very much. I'll stop sharing.
Thanks, Shaun. That was a really brilliant overview of the added benefit of stress echo in valve assessment. I think there's really lots to consider, and clearly it's highly specialised. There's a lot of information to consider and interpret, and probably a lot in terms of triaging and making sure that we're sending the right patients for the right assessment, which I'm sure we can go into a bit more in the panel discussion. So thank you very much. So next up, we've got Casey Johnson. Casey is the clinical project manager for BSE N-StEP, amongst other projects, and he's got a very important role because there's clearly a lot of patients that are recruited, a lot of centres involved, and he really runs the show and coordinates everything. But what he's going to talk to us today about is the role of AI in stress echo. Thanks, Casey.
Yeah, thanks for that. So give me just a moment as I share my screen. I do have the luxury of having 3 screens to choose from. So give me just a moment there. We should be at the title slide. I'm looking, there we are. So yes, so thank you again. I am Casey Johnson. Nice to see some of you and meet some of you. I do recognize a lot of names as the attendees of people I've worked with before. So yes, I am the project manager of the BSE N-StEP study and also of the PROTEUS study, which we'll talk about a bit in this slide set. And I do recognize a lot of names from both of those. So thanks for coming. And in the interest of time, I'm going to start talking a bit fast. So just hang with me here. We can obviously get to questions if we need to a bit later, and these are being recorded. So with that, I'll crack on in AI and stress echo assessment and the PROTEUS study. So quickly, I'll go through an agenda for this slide set. We're going to have a background and rationale. We'll then be doing addressing challenges in stress echo, an introduction to EchoGo Pro, which we'll get to in a bit, and an introduction to the PROTEUS study, and then where we are currently with the PROTEUS study as well. So that's the background and rationale. So we're all going to be talking about coronary heart disease, which Paul's already mentioned a good bit about this in the past in his talk earlier. So I'm not going to go through this too much, but what we kind of know here is that cardiac disease affects around 6 million people in the UK. And the UK required scanning capacity is around 335,666 per year, as you could see, if we needed to scan everyone with CTCAs. And this has come up here with the ESC guidelines suggesting non-invasive functional imaging, or CTCA, in those with suspected coronary artery disease that cannot be ruled out by clinical assessment alone. However, then the NICE guidelines actually suggest CTCA as a first-line investigation with non-invasive functional imaging lower tiered. And then there are barriers and uncertainty that surround CTCA adoption in the UK, and a lack of infrastructure and a lack of expertise. So we're looking at thinking that stress echo, as its capacity you can see is around potentially 350,000 a year, could address the concerns with that we're not able to ramp up our CTCA capacity in the UK to meet these NICE guidelines. So with that being said, we're looking at stress echo as going forward. Now, there are challenges, however, with stress echo that will need to be addressed and thought about. And these are the accuracy ranges from around 60 upwards to 94%, as you saw in Paul's speech a bit earlier. And then the Everest results, of course, as Paul mentioned, the accuracy was sitting around 95.9%. So still just giving you a flavor of the wide variability in reported accuracies. Stress echo also requires operator expertise and the potential for inter-operator variability. So a lot of these factors are going into the challenges associated with stress echo practice. And this comes with a risk of false diagnoses, which can then lead to an increase in unnecessary interventions, which then thereby could lead to an increase in undue health costs across the NHS. So how do we address this? So the idea is potentially, could artificial intelligence help address these challenges? A lot of the challenges that I just spoke about on the previous slide are challenges not just with stress echo, but across a wide variety of clinical procedures, the variability across operators, variability, across sites. So can AI help address these challenges? So then we had an academic investigation that came place, the investigation that helps begin the work towards PROTEUS. So this began as an academic investigation to identify if AI could be used to address challenges with stress echo practice and perhaps increase efficiency and standardization. So this focused on developing reproducible, accurate, and easy to use quantitative techniques for stress echo. Ideally, this would look like things that are automated, require limited operator input, available for both pharmacological and exercise stress echoes, available with or without the use of contrast, the ability to analyze regardless of ultrasound machine vendor, as there can be a wide variability in vendors across the NHS and across the world, and produce results that are readily understood by clinicians. So that's obviously quite important as well. If the AI generates something that only the AI can understand, it's not actually going to help the clinicians that need to have that information. So then this is a brief introduction into the AI and applying AI intelligence to stress echo practice. So where we fell with this currently is that AI has been recently used in cardiovascular medicine. And for us specifically, an algorithm was developed by the University of Oxford spin-out company Ultramics. And this is the first automated AI pipeline of algorithms to mimic the clinical workflow of stress echo image processing. Now, that being said, this algorithm also incorporates global and regional geometry and wall movement of the left ventricle, and also convolutional measures of left ventricular volume, ejection fraction, global longitudinal strain. A lot of the metrics that commonly go into stress echo practice have also been used in this algorithm as well. And this algorithm then also produces a binary result of either a high or low possibility of severe coronary artery disease. And a lot of this information has been published only recently by Upton et al. In the JACC imaging here, as you can see the kind of headline here. And more than happy for you guys to try to take a look through that a bit later. In the interest of time, I won't go into it too much, but that is just a recent publication. Now, what about this AI model training and validation? So we've talked about that the algorithm was developed, and what about the training and validation? Kind of where did this come from? So training data on the algorithm is provided by a small number of Everest sites that were mentioned earlier in Paul's talk. So that was that small bit of the Thames Valley area trusts in the earlier lifespan of Everest. And this is where the acquired images sets were gathered and utilized. And then additional training and validation was performed to assess the algorithm performance. So in the training data of around these 579 UK patients that were gathered from those first few Everest sites, then there was the area under the curve of 0.93. And I'll go ahead and just release the rest of these now and pull up some of these pictures here. So this is the area under the receiver operating characteristic curve of 0.93 that is represented in the training and validation of this study from these 579 patients. The algorithm was subsequently independently tested in a set of 154 US patients and found to have a similar OROC of 0.924. And I'll go ahead and pull that up here. And in a randomized crossover multiple reader study of the 154 patients, the ORAC for the readers alone was 0.882. And when the readers were assisted with an AI algorithm, this increased to 0.946 there. So just to give you an idea that this really was built off the heels of the Everest study and from participants that were gathered in the earlier iterations of Everest. So just kind of one idea as we're looking towards project proposals, this would have at one point in time been something where we took a look at the Everest data set and said, you know what, this is something we can do with this data set. And then this is where we've come with that proposal into a full-fledged randomized control trial. So then just a bit of introduction into the actual algorithm, as I've been mentioning, that's come to be the software we know as EchoGo Pro. So EchoGo Pro is an AI software. So here's a quick overview. Before we can process any measurements or identify a risk prediction for this coronary artery disease, we have to kind of run things through. So just a quick overview. You have the input video of the stress echo procedure. There's some view classifications that happen at that point. There's automatic contouring of the left ventricle. You can see these little moving pictures here of what those contours look like in the left ventricle at different views. Then there's cycle selection of end-systole and diastole and in between. and then some feature calculation, and you can see just a few of those metrics mentioned here, GLS, volumes, ejection fraction, that then ultimately come out to have that CAD prediction of either high or low coronary artery disease. And again, just a picture of what some of those contours look like on the left ventricle for various different views here. So then the reports that would be returned back to the clinician at the site look like this. So you're either going to have a red or a green, the red being suggestive of a higher possibility of significant coronary artery disease, or the green being suggestive of a lower possibility of significant CAD. That then detects significant CAD as greater than or equal to actually 70% stenosis CAD from the stress echocardiogram and provides this binary processing result to the clinical team. And then just a bit quickly about the PROTEUS study in the interest of time. Some people who have joined, I see, actually are currently recruiting to the PROTEUS study. So the study aim then is to present robust evidence for health and care improvements enabled by Ultromix's EchoGo Pro AI diagnostic tool. We expect the use then of EchoGo Pro in the clinical pathway to have a significant benefit at addressing some of the concerns that we've talked about earlier with stress echo, reducing inter-reader variability, increasing accuracy, and thereby hoping to reduce health costs across the NHS. And then the study design then is a randomized controlled trial comparing the management of patients being referred for stress echo investigation of myocardial ischemia with and without the aid of EchoGo Pro AI analysis, randomized 1-to-1. So again, all of this has just come out of the algorithm that was built on the backs of the earlier iterations of the Everest study. A bit more about PROTEUS quickly then. Again, prospective randomized control trial evaluating the use of AI in stress echo. Primary objective then is to investigate if stress echo plus EchoGo is non-inferior to standard care alone in predicting the risk of coronary artery disease following a stress echo. Primary outcome is the ability to make an appropriate referral for coronary angiogram. And we're looking to recruit up to 2,500 stress echo studies up to 20 NHS trusts, with a follow-up period of around 6 months following their stress echo. Just to give you a background of where the funding, this is a non-commercially funded study, the PROTEUS study, there it is, an NHSX Artificial Intelligence and Health and Care Award. The Artificial Intelligence Award benefits patients by combining the power of AI with the expertise of the NHS to improve health outcomes across the NHS, fits into the NHS long-term plan. Non-commercial NIHR NHS funding awarded across 4 phases, and Ultromix as a company were able to receive that award for their phase 3, which is the PROTEUS study, intended to support first real-world testing in health and social care settings to develop evidence of efficacy and preliminary proof effectiveness, including evidence for routes to implementation to enable more rapid adoption. And just a quick overview of that timeline, then that grant would have been submitted in April of 2020, awarded in June of 2020, and the contract signed in November of 2020. And then here we are going into the end of 2022 here. And just a quick overview of the NHS AI award. There's just a kind of a templated buzzwords here of what the NHSX award looks to do. Lots of funding, lots of technologies implemented, lots of sites across the NHS, and all just to benefit the NHS long-term plan of improving health and patient care. So the NHSX phase 3 program, the PROTEUS study, has 3 arms: the clinical impact in arm 1 to establish the AI accuracy of the CAD diagnostic tool with the randomized controlled trial with the 2 treatment groups. There's also the social impact of exploring perceptions and experiences of the implementation of EchoGo Pro with a qualitative sub-study. And there will be an economic impact to assess how the EchoGo Pro results with standard care and decision model for recommending the best NHS adoption strategy. The trial design then, as I mentioned, it is a randomized control trial. Patients are randomized 1-to-1 to either the intervention or the comparator or control group, and then followed up for 3 and 6 months. And just a bit about the deployment of this EchoGo Pro technology. So this is kind of just a big overview of how this looks like. So basically, you'll have your PAC system at your trust. I'll go ahead and put these up here. The images are acquired in the hospital. They're then sent to the PAC system. They're then anonymized and transferred to EchoGo. EchoGo provides an automated test for data corruption, performs image analysis, quality checks to inform an accurate analysis, and then sends a DICOM image of that binary report back to the trust. And then the trust clinicians are then able to view that binary report in their stress echo, reporting pathway, and take a look and see what the EchoGo Pro software has thought about that stress echo, and use that as a diagnostic aid potentially for their referral for that patient's care pathway. So then quickly, our journey to our live sites. We do have some sites currently live, but just to give you an idea of what this looks like for the trial, the contract, like I mentioned, was signed in November 2020 for the funding. Ethical approval obtained in July of 2021. 30 sites began to express interest, and we began engagement with sites in August of 2021. First 2 sites went live in October, and the first patient was recruited in November of 2021. And then a bit about the site onboarding workflow. I won't go into this too much, but we do typically have a feasibility call just to align with the clinical personnel at the trust. We then split that into 2, where we talk about a data protection impact assessment just to make sure we're doing everything appropriately by governance standards. We then have some IT considerations where we begin establishment of a VPN for the purposes of image transfer. Both then can go forward to contracting, where we'll liaise with trust R&D for that bit. And then we'll also have an image visit where a member of our team will come visit just to take a look at how images are acquired and give some tips and guidance for best practices that will fit with the EchoGo Pro software for analysis. We then converge on an actual site initiation visit where we just go over again some expectations and trust responsibilities right before the trust is ready to go live. And then the trust does go live, and then they have patient recruitment and follow-up with some continuous monitoring. And quickly, where we are currently. The implementation has gone well. We have 8 live PROTEUS sites, 6 to 8 additional sites coming on board in August, with 18 sites about projected live by September. Here is another map of kind of the sites that we currently have live in green and the sites that we're looking to onboard a bit later in yellow here. Around 570 participants currently recruited. I updated that just a few days ago. And just a nice little snippet here from Dr. David Ripley at Northumbria. EchoGo can detect features that would have been impossible to detect using traditional software. EchoGo has the potential to improve the diagnostic accuracy of predicting CAD within our trust. And with that being said, that's the end of my really quick talk. But again, just to highlight the fact that this really was built off the heels again of the earlier iterations of Everest. And it was just at one time a project proposal that went forward and now has developed into something much larger that's looking to improve patient care and implement AI wherever possible to address challenges. So with that, I'll say thanks for listening. And I'll stop sharing my screen.
Thanks, Casey. I think obviously the prospect of AI in echo in general, but particularly in stress echo, is really exciting, and it means that we can absolutely try and raise and maintain the standards in the quality of practice happening, and really puts us at the forefront of research in this area in the UK. So it's a really exciting prospect, I think, there. And next up, so we've got Reinette Hampson, who's a specialist cardiac physiologist at London North West University Hospital. And Reinette's already been mentioned in James's talk previously and has published a lot on the area of physiologist-led stress echo. So it's really exciting to have her here to share her experience today. Thanks, Reinette.
Maria, can you see my slides?
I can indeed,
okay,
yeah.
Hi. Yeah, thank you very much for giving me the opportunity to contribute to this webinar today. As we've heard from James earlier, it's clear that various models for stress echo clinics are being used across the UK. And I dare say that the major factor that will determine your model is the relevant skills and experience unique to your local workforce. It's, however, not the only factor, and I will try and touch on all the various aspects you'll need to consider if you're thinking about establishing your own model for a stress echo clinic. We'll briefly discuss the key elements of a stress echo clinic. There isn't a lot of time to cover any of these in great detail, but I'll try to give an overview. These are the main aspects to consider. The contents of my presentation is based on local guidelines from the British Society of Echo, and obviously some experience from our own centre. And you can find these very nice guidelines in our own Echo Research Journal. Now, since the publication of the GIRF report last year in 2021, it definitely feels that a clear mandate has been given to make every effort to upskill our workforce and create roles for advanced clinical practice in order to meet a growing demand and deliver care in the most effective and cost-effective way. Now, as we've heard before earlier on from James, the two main areas that have emerged under this mandate in cardiology seems to be devolved valve clinics and stress echo clinics. There's plenty of evidence in the literature, as James has shown, on the success of valve clinics, and more recently also on the success of these roles being deployed in stress echo clinics. There are some of the publications I could find on sonographer-led stress echo clinics. Compared to valve clinics, there are plenty more. Now, I dare say sonographer-led stress echo clinics, and I just would like to clarify that I'm just making reference to all of us as sonographers. That includes physiologists, sonographers, clinical scientists, just for the purpose of, I don't know, just to include everyone, just talk about sonographers for now. And as I said, compared to valve clinics, sonographer-led stress echo clinics have the added challenge of having to administer prescription-only medicines. Now, probably the reason we don't see quite the same enthusiasm for setting up sonographer-led stress echo clinics as we do for valve clinics. Now, the main aspect that is likely to determine the model you settle on in your workforce is your workforce, your personnel, not just their skills and experience, but their professional status, because this will determine how you go about prescribing and administering the prescription-only medicines required for a routine stress echo list. And we will talk about this a little bit later on. Competence and accreditation, James has also mentioned that a little bit. And just briefly again, what is the optimum training requirements to become a competent stress echo operator? Now, to start with, we would expect a stress echo sonographer to hold BSE or equivalent transthoracic accreditation. This will underpin your basic knowledge. Additional training in stress echo will be required, in particular in the evaluation of myocardial ischemia, myocardial viability, valve disorders, and cardiomyopathy. In the past, it was typically considered that 100 stress echo studies would be sufficient to build an individual learning curve and reach a plateau of diagnostic accuracy. However, stress echo has evolved significantly over the last 25 years, with indications for stress echo broadening considerably. There are no recent studies to suggest how many stress echo cases are necessary to gain experience in modern practice. In the absence of such data, it's traditional that this can be determined by the consensus of experts in a given country. Accordingly, the British Society of Echo has developed and introduced accreditation in stress echo. In keeping with the format of transthoracic echo and TOE accreditation, candidates must initially pass a written exam. If successful, they will be invited to attend a practical assessment, followed by the completion of a logbook of 200 cases and 5 video cases. Now, although it's believed that 100 stress echo cases should be performed annually to maintain competence, initially the experts at the BSE believe that at least double that is required to achieve competence across the spectrum. Additional training will be required to run a safe clinic, at least ILS, preferably ALS, and some extra training like IV cannulation and drug administration. Next, the equipment, just briefly, it will entirely depend on your protocols. There are a variety of different protocols you can select for any study, whether it's an ischemia study or viability. You can use either exercise or pharmacological stress, and even then you can either use a bicycle or a treadmill. And as for the stress drugs, you can use dobutamine or a vasodilator. It will probably depend on operator experience and preference. So in the next slide, we'll look at potential variations on different protocols you can choose for any different study. Now, once you've decided what kind of stress test you are most likely to perform, you can acquire all the necessary equipment accordingly. And one of the reference papers, there's a very comprehensive list of everything you might need to set up your own stress echo clinic. The only thing to add is, of course, the ViewJet pump, essential for myocardial perfusion, if that's something that you aspire to in your clinic. That is also very useful to do dobutamine studies. It provides a steady state of contrast infusion and produces nice homogeneous opacification. It's also very important to consider the physical space you have available. The BSE has published requirements relating to the size of a stress echo room and takes into account space that you would need during scanning that would allow for a crash trolley or a defibrillator next to the patient. There should be enough space to run an arrest scenario with full cardiac arrest team present. Now, protocols, we can have an entire lecture on all the protocols, and this slide just touches briefly on all the possible variations that you're able to choose, depending, as we mentioned before, on your experience and your expertise and or your preference. As you can see, there's quite an array of protocols you can choose from any different indication. There's really no right way or no wrong way to do a stress study. It all just depends on your skills, your experience, your preference, and what you have available in your center. Like I said, we can have an entire lecture on just this. The main aspect that's likely to determine your model that you settle on is your workforce and your personnel, not just their skills and experience, but their professional status, because this will determine how you go about administering prescription-only medicines. So typically, these are the medicines that we will prescribe in a typical stress echo scenario. We've got our ultrasound contrast, atropine, dobutamine, adenosine, diprodamol, regadenoson, aminophylline, metoprolol, and your anaphylaxis drugs that you would necessarily be required to administer. By the time that you would require these medicines, you would have called for help, depending on the scenario that you run in your center, and you would have a doctor it's available to administer these drugs, or you will call your crash team and they will do that for you. Now, the way we go about in practice enabling sonographers, that will include physiologists, clinical scientists, and sonographers that are neither clinical scientists nor physiologists, to administer prescription-only medicines is through the use of a patient-specific direction. And basically, all this is a prescription. It is signed by a doctor. Once that doctor, or not even a doctor, but an independent prescriber of some sort, it could also be a nurse prescriber, has reviewed a patient for their suitability to receive contrast, and you will then go away with a prescription and you will be able to administer contrast. So in order to set that up, you will have to work with your local drugs and therapeutics committee. You will work with your consultants, and you will put together a guideline that you will present to the drugs and therapeutics committee. And at the end of all of that, all you will produce is something like this. It's basically just a prescription that at the end of the day will enable you to independently administer things like contrast in our own center as a result of our success of administering contrast safely. We have gone on to have a PSD approved for atropine and dobutamine as well. This is what our prescription looks like for dobutamine and atropine. We kind of try to incorporate everything on one prescription form. And then this is, once you have everything in place, you will consider your setup. Just give me a moment. Yeah, once you've established your model and all you have to do is perform the studies, you will need to write a standard operating procedure with clear steps on the setup, your performing, reporting, communication of results. And we'll just skip over the performing. I mean, this will all be in your standard operating procedures and reporting. In the guidelines, there are very clear guidance on what a minimum report should contain. I would just like to add one thing, following on from what James has said about stress echo accreditation. If in your center you perform your stress echoes independently, but you don't report them independently, please don't be discouraged from undergoing the accreditation process. It is not required of you to report your studies independently while you go through the accreditation process. We will accept reports that have been reviewed by consultants, but you should obviously be working towards reporting them independently. But if you write the report yourself and you still have someone who review it at the end of the day, that's more than sufficient to achieve accreditation. And yes, please don't be discouraged from undergoing this process if you're not 100% independently reporting your own studies. And then my take-home message or a communication, obviously, was very important. If you, as a physiologist, are running your own session and you don't have a clinical person with you, and you have an abnormal study at the end of your session, the responsibility lies with you to report these findings to the relevant clinical personnel. And then my take-home message: let's do it. Where the skills and resources exist, we should encourage centres to establish sonographer-led stress echo clinics. The mandate is clear. Let's upskill our workforce, let's empower people and encourage the improvement of services to meet our ever-growing demand. Thanks, Maria.
Thanks, Reinette. That was brilliant. And it was really empowering, actually. And you gave us all the components to really run a successful stress echo service. And a few really important points you raised about the accreditation service as well. So I think that's really brilliant.
Yeah, I'm on the accreditation committee, and if anyone needs any help or any guidance, any documentation, anything, please reach out. So happy to help.
Brilliant. Thank you. That's really supportive. So I think we'll go straight into the panel discussion if we can now. So we've had a few questions come in. So if it's okay with everyone, I'll direct a few and we'll see where the discussion leads. We've got the first one. I don't know if, Shaun, you might be able to answer this quite thoroughly. There's a question about, has the measurement of GLS been validated in post-exercise in patients with higher heart rates? Which we know that's quite a complex issue because there's a lot of components to consider there, but obviously there's a lot of data coming out about GLS and stress echo, and there has been a little pause in some of the literature and some of the evidence base. So I don't know if you can summarise that.
Sure, yeah, I think it's a very, very good point, very important point. Pardon me. I think we'll obviously find that during exercise we'll have greater intra-observer variability with strain at the higher heart rates than we would do the lower heart rates, which emphasises James Willis's point, Reinette's point about competence and developing that expertise and skill. Technical considerations, obviously frame rates need to be very high, approaching 80 or 90 frames per second to be able to get good strain parameters, and also image quality as well. So I think there's lots of caveats, but when it can be done, and it can be done by people who are experts and who've got good level of competence, it's been proven in both coronary artery disease as a good indicator of regional dysfunction, but also in valvular disease as well as identifying limited contractile reserve. So I think it's a very, very fair and good point that there are limitations to strain. Some of them we may be able to overcome, and certainly that comes with expertise, but when we can do it well, but also bear in mind the limitations. So if we interpret this, we have to be completely sure that what we're interpreting is a true measure of deformation. And I think that, again, that could be probably made easier by, rather than just doing baseline and peak, which would be a limitation of treadmill. If we can do this serially, we're probably going to get a much better idea of what the true strain parameters will be.
Brilliant, thank you. And I guess something that just leads on to that, actually, which Reinette might be able to sort of pitch in on, and is how prescriptive you refer patients for stress echo. So do you tend to have patients turn up and you decide as the advanced physiologist on the day what kind of protocol they're going to go through, or do you go through a really careful triage process to make sure that you've decided that well before time?
Yeah, I think we're actually quite lucky because we have 2 bicycles, 2 treadmills, we have infusion pumps, perfusion pumps, we have diaprodamol, and we have everything, and we're all able to do anything. So we really just decide on the day, what's best for the patient. Yeah, we're just lucky because we have the experience, I think.
Brilliant. And then another question that's come in is just what the challenges and barriers have been really that you've found setting a service up.
Yeah, I think also talking to other people, it's the support you have for it. We've been quite lucky here that our consultants really support us. The Drugs and Therapies Committee, all pharmacists, the whole hospital, everyone, they're all very supportive of it. And I think you really need a champion behind you. Whether it's your lead imaging consultant or anyone, but you really need to get someone on your side, you know, a stakeholder, someone that can really champion you and help you through the process. That's really the only obstacle. If you don't have the support, you need to get someone on your side.
I really would echo that. I think I found that throughout my entire career. And I suppose whilst we're on the topic of support and championing physiologist-led services and physiologists sort of doing things outside the scope, it's a really good opportunity to highlight how hard Paul and Casey have worked really on getting physiologists on board with BSE N-StEP, because they went really far in making sure that physiologists could be PIs on the project. So that's a hugely influential step for UK practice in research. And I suppose, Casey, if we can turn a bit more to the research side of things, obviously PROTEUS at the moment is recruiting sites. What are some of the benefits that you think there are to some of the sites getting on board? Obviously, it's a really interesting and stimulating area for people to start working in, but there's lots to consider as well.
Yeah, certainly. So before I answer that question, I should at least say that we currently have the sites that we have right now, and it is closed to additional sites. I did just have one email come through asking to how can they join, and I appreciate the enthusiasm, and we might have things coming in the future. But yeah, currently, yeah, really good. I mean, what we're experiencing with a lot of these trusts that we've worked with PROTEUS is that this is the first foray for them into artificial intelligence at all. So it's very exciting to the clinical team to try to see how that's going to implement and how that's going to integrate into their workflow. So we'll have to see a bit later down the line what everything kind of shakes out to look like afterwards in the validation and the data analysis part of things. But yeah, it just looks like a lot of the trusts are really excited to implement this into their clinical pathway, because so far they've not experienced anything like this, and it's a good kind of guinea pig also for a lot of their internal processes to finally know how to handle AI projects effectively, because we're running into a lot of questions around progressing AI projects. So we've been good to help those trusts through with that through the PROTEUS study as well.
Maria, can I also just say, you know, all of us, I mean, Shaun himself has published, you know, it's evidence-based medicine, isn't it? And, you know, some of us who've been doing it for a long time have actually tried to collect evidence and publish and show that it is safe. So, you know, if you need to convince someone on your own team that, you know, it's safe and, you know, we're good to do it, then, you know, just make reference to whatever is out there. There's quite a lot of publications out there now to show that it works and, you know, it works safely.
Yeah, absolutely brilliant. And there are, again, just a shameless plug for the research clinic, which happens because actually if people are interested in getting involved in research, but people might have joined that very early in their research career, then please come along and there'll be a whole team of us that would help you. There isn't one before the deadline for the expressions of interest, but this really should have given you a really thorough sort of understanding of some of the data that might be available to you to be able to put together a proposal. And we're really keen to have people sort of from every sort of area, every career profession, really go for that expression of interest. I'm sure you'd echo that, Paul.
Yeah, I was just going to jump in on a couple of those points, which are really, really nicely made, I think. Stepping back to that point about the different types of professionals who are contributing to stress echo, I think that really came, the fact of creating an opportunity and amending the ethics to allow physiologists to be lead PIs on the study really came from the sites themselves, actually saying, actually, we have stress echo clinics. We're sure we could get a consultant to be the PI, but it doesn't kind of make sense because actually we're driving the service. So that was the amendment we put in to allow that to happen. I'm also aware of the possibility of bringing on individuals who may be interested in doing research. And one of the things I'd probably highlight is, so one of my other hats is as one of the cardiology leads for the National Clinical Research Network, and there is what's called an associate PI scheme, which we are quite keen to have Everest as part of potentially, or BSE N-StEP as part of. And if there are any physiologists who don't feel quite ready to step up to being PI, but would like to help with the process in the existing BSE N-StEP centres, we could certainly get them enrolled in that scheme, and then they could work alongside whoever the PI is, have some, and through that they can get some training, they can get some recognition for being part of the process. So if anyone's online and would be really interested in trying to help out, and that could be also cardiology trainees as well in a centre where this is running, would like to help out with the study, not ready to be PI, but would like to register as an associate PI, then we can facilitate that. And if you sort of get in touch with Casey or someone on the call, we can sort of put that in process. So I'm keen to promote that, because I think that's a national NIHR recognised role that we can promote. I mean, I think in terms of the stepping in on the research concept we want to bring through, I think this is a great opportunity, and we're kind of open to all ideas here in terms of what we have in terms of data set. And indeed, we have a recruitment plan for the next 6 months and or follow up over 10 years, but also in terms of proposals of where, you know, having a research network of 32 hospitals who are doing echo-based studies. You know, thinking about that as an infrastructure which can deliver projects, pretty complex projects. You know, something like PROTEUS is not easy to deliver, but because the centres are really involved and engaged in what's going on, you know, you can achieve amazing things. You can get IT set up within hospitals. You can deliver AI reports right into a stress echo clinic, which, you know, to be honest, I never thought would be at all possible 5 years ago. But literally, you know, within 10 minutes, I can get an AI report back on my stress echo. So, I mean, that's one example. There are other possibilities I think you could do with it kind of infrastructure to run research studies across the network. So I think this is the call to arms for the British-sided echo. Actually, yeah. Well, what is it we actually want to do with the echo? You know, with the people doing the echo, what is it we'd like to do? What we'd like to do in the future? And you know, we've got a great opportunity here to make stuff happen.
Absolutely, thank you, Paul. I've heard about some of the regional schemes actually for the PI Associate, and I think they've worked really well for a lot of different professionals. So I do think that'll be something that will be of great interest to people, and it's a fantastic stepping stone to getting into that kind of arena and gaining some experience. But certainly this is part of a broader conversation for the BSE and the research agenda for the BSE, and trying to open that up so that we've got a whole, like you said, a whole national network of people contributing to really stimulate where we go with guidance, with future research, and that we can help really contribute to the literature worldwide. I think that's BSE N-StEP has really showed us the power of some of this information and the data that we can get our hands on. I think that's really important. So I think that's everything for questions. I don't know if you had any further sort of roundup comments, Paul.
Yeah, good. So, I mean, I was just going to say thank you very much to everybody, and it's been a real privilege sort of to work with British-sided echo to set up BSE N-StEP, and I would probably acknowledge people who aren't on this seminar webinar and their input. So particularly, I'd like to sort of flag Dan Augustine for his kind of vision of linking this together, which, you know, he has to take credit for already, I think, in terms of bringing this about. I mean, he was in very early of, you know, that very phase 1 of Everest. He was actually a student with me in Oxford, and it's great to see that track through and then create something like this. So I think very credit to him and his ongoing chairing role of the committee as well, to sort of guide this moving forward. I think thank you very much also to the speakers. I think I've learned a lot from Shaun's talk. Actually, that's been really interesting. Actually, I don't do enough about stress echo, to be honest. I should do more myself. I do lots of ischemic heart disease stress echo, but I don't do enough about. I think that's really given me food for thought about how we might be able to do more in Oxford as well. Reinette, I mean, I think that knowledge about how you set up, you know, I've been lucky in that I came into a service that was already set up, and I can see there's a lot of work, you know, that is entirely achievable. But if you want to get stress echo set up, there's some really things to think through. Thanks to Casey, I know that talk well, so that's great, and thanks very much to Maria for chairing in a very elegant way in terms of bringing all those thoughts and comments together. So that's been great, and thank you very much to Hattie and the organisers behind the scenes who made this webinar the professional webinar it has been. And finally, thank you to all the participants who I see we had sort of peaked at about 80 participants, and I appreciate some people may have drifted off to lunch or afternoon tea, but it's still down at 75 at the end, which is a good sign that actually, you know, hopefully everyone has found that enjoyable. So thanks very much. The next stage has been highlighted is the expressions of interest. 5th of August is the closing date, so the end of next week. I think that our plan is to look through those, and I think if you are thinking about an expression of interest, do think of this as a joint collaborative process. So, you know, the committee will be who are running the BSE N-StEP are keen to work with people to make things deliverable. People won't be, if you're interested in doing some research, we will work with you to make sure that's possible, but make sure that you get the credit for that work as well. So we're here just to really facilitate those ideas as they come in. So I look forward to seeing those and sharing those within the future. So thank you very much. Maybe hand back Maria for last word.
Absolutely. I just want to do a few more words of encouragement to anybody who is potentially considering anything. And if there's any queries, please reach out to us before the deadline. We'll be more than happy to support anybody going forwards. But hopefully that's been really interesting. And again, everything that has been recorded, so it'll all be available in a few days' time. Thank you so much, everybody.